All right, so let's start with benzos. So we're gonna talk about benzodiazepines and we're gonna talk about Versed, Ativan, and Valium. I don't care about the rest. So benzos work on the GABA receptors, obviously. GABA receptors has two binding sites, by the way. One for the GABA, one for the benzos, for example, and the other for alcohol, and the other one is for barbiturates and propofol. So they all bind to the same receptor, but from two different binding sites in the same receptor. So for Versed, the onset of action is 2 to 5 minutes. The duration of action is 30 minutes, and the half-life is 8 hours. Yeah, and we talked yesterday. We said 8 hours because that's the time it takes for the concentration of Versed to go in the blood to go to half. But that doesn't mean that the duration of action is 8 hours. The duration of action is only 30 minutes because the duration of action is determined by redistribution when the Versed leaves the brain. Medications that work in the brain have to be lipophilic because to go into the brain, and lipophilic medication hurt the veins. They become they are caustic to the veins. Versed resolved that issue. Versed is hydrophilic in a vial, and then once injected in the body, it becomes lipophilic in the blood when it goes in the blood. They say that it has a certain composition and a certain vehicle that's holding it, and then when it goes inside the blood, it separates from it and takes the shape that makes it go into the brain. So that doesn't hurt the veins, which make now Versed the king of procedural sedation, because we can use the Versed, as I said, for procedural sedation. There's no competitor for Versed anymore, and the dose usually is 2 to 5 milligram IV boluses. And there's three things that affect the dose that you're giving. Most people will think about one, which is the dose. They say, how come you're giving the patient 4 milligram of Versed for a central line? Don't give her that. I gave her 0.5 milligram of Ativan yesterday, and she slept the whole night. But she didn't have somebody stabbing her chest during the time that this was happening, right? So there are three factors: the dose, the amount of stimulation that you're doing to the patient, and the timing, right? And the timing of the stimulation. For example, if I take somebody and give him, if I take you now and give you 500, let's say, give you 50 mics of fentanyl, right now, and we all leave the room and turn the lights off and leave you, you're probably gonna be dead. Unless I know something, unless you do something I don't know. But if I give you 500 mics of fentanyl and cut your finger, you're gonna be screaming at the top of your head, and you'll be like crying and breathing so fast, and you need more fentanyl. So it's all about the stimulation that you're doing. Central line is different than other things, right? Also the timing. So the rule is, as you see, when we do the central line together, I have a certain way, or we all have a certain way to actually open the central line fast, even though I'm not in a rush. Because when you give the Versed, right, you have 2 to 5 minutes to reach that peak, the nice peak of the sticking. So give the Versed, tick, 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 open. By the time I'm sticking the patient in the chest, what happens? It's the highest level of Versed. By the time I'm done with the procedure, 30 minutes. I'm wrapping off and leaving the room. Hopefully we'll do it faster than that, but at least at that time the patient is waking up, right? Very, very important, that peak and the end of the time. For example, one of the nurses here before, she didn't tell me, but she confessed at the end. She said, I wasn't, so basically what happened is that, it was an old patient, so I said 4 milligram of Versed, right? So she comes in and she doesn't give the 4 milligram. She says, I can always give the other 2. So she gives 2, that's that conception. Huh? So she gave 2. And we're okay, I don't know that she did that. I was struggling, the patient is moving too much, blah, 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 blah. And then she saw that we're struggling, so without telling us, she said, she gave the other 2. Then we finished. Then the patient, we finished like 5 minutes after she gave the other 2. I mean, we were struggling, and then she gave the other 2. Patient calmed down, we got it, and then 5 minutes later we're done. This patient became blue, cyanotic, had to go on BiPAP after we left because there's 2 milligram that's unopposed, right? So, number 2, intubated patients. So we can use this for intubated patients, and the dose is 0 to 0 to what? Milligram an hour. 0 to infinity. There's no upper limit for Versed. Every hospital has to choose a limit. Some hospitals use 10, we use 20 here. Doesn't matter. Everybody has to put a number just for the computer so we can have a range. But what we're telling you is that number, the maximum number that we're putting, is not a maximum that you can never go above. It's a thinking threshold. It's a threshold at which you say, okay, we have to think of giving the patient something else, or something else is happening to this patient, right? But you can always go up. We had a patient here who abused Xanax, but he also was a chemistry major, and he goes down and makes Xanax in his basement. Like, he sensitizes the drug, and he takes 90 milligram of Xanax TID. So try to give him 20 milligram an hour of Versed, it's gonna be like he was running at 60 milligram an hour of Versed. Yeah, so stuff like that. 2 things I have to tell you about the intubated patients. Number 1, renal failure. Patients who have renal failure Versed has an active metabolite that will accumulate in cases of renal failure. And individual variability. So what do you do for somebody with renal failure? Some people have phobia of Versed because of renal failure. Anytime the creatinine is up, it's like, oh, you can't use Versed. That's crazy, right? What you need to do is that you wake the patient up more. Like, you be a little bit more careful and wake the patient up more to wash the Versed off. Number 2 is individual variability, and this is something that's not, we're not talking about something obscure in somewhere, This is it's not even in a study. It's not an opinion. It's actually in the packet insert. I'm sorry, in the old books about Versed. So it's something that's already established, which is, we don't know. Like, in some people, we don't know why Versed takes a little bit longer than others. Medications have there's some medications that are known to have more individual variability, sometimes it's not even written. It's just people who use it know that they have a little bit of individual variability. Most of those have individual variability. Like Ativan also has a lot of individual variability. You've seen. You give Ativan, it's sometimes less for 5 minutes, sometimes less for a few hours, right? And Versed is the same. Rocuronium is the same. Rocuronium, out of all of the muscle relaxants, for some reason, Rocuronium takes variable amounts of time. So that's, just keep that in mind. It has nothing to do with, when I came here to this hospital, they had the idea that Ativan is shorter acting than Versed. And I was like pulling my hair. Why are you saying that? And I, kind of found out that they had some disasters on Versed. So they arrived at this anecdote. Number 3, it can be used for seizures, but of course, not preferred, because in 30 minutes you need to use something else. But if somebody's intubated, obviously you can use it on seizure, no problem. And then number 4, DTs. And also, again, not preferred for SIWA because of the 30 minutes half-life. But if somebody's intubated, they can use it. But can I ask you this? Have you ever seen somebody on Versed drip not intubated? Never, right? You'll be written up if you try to write an order like this. Why? But we've seen, I don't know if you, when you were not born yet, that we used to use Ativan, like I would say like 8 years ago or something. There was Ativan drips for alcoholics was the standard of care for alcoholics in the ICU. Alcoholic comes in, Ativan drip. So why can you use Ativan drip in a non-intubated patient, and you can't use Versed drip in the non-intubated patient? So all of those give you respiratory depression, right? But the difference is the therapeutic margin. This one has a very narrow therapeutic margin, meaning that here at 10, for example, the patient is jumping off the bed. I go up to 12 to calm him down, he's apnea. So it's narrow therapeutic margin, which is the drug that is worse than Versed, actually. Narrower therapeutic margin than Versed for the brain. Propofol is amazing. You can't. It's really very difficult. That's why it's never used in ICU, also in a non-intubated patient. I ordered this when I was young, and I forced the nurse to do it. Presidex was so expensive then. But the only place that uses propofol in a non-intubated patient is the OR, because you have the one anesthesiologist, one patient, right? And you can just lift the chin a little bit, adjust the propofol a little bit, stop the propofol. You can do whatever you want, right? But you can't ask the nurse to have the same amount of time. So that's that. Ativan is a wider therapeutic margin, much wider. So it's very much forgiving. And Valium, I have yet to see the end of that therapeutic margin. You really can't put people apneic with Valium alone. It's difficult. You have to use industrial amounts of Valium. So we'll get to that when we get to it. Ativan, onset of action is 5 to 10 minutes. Duration of action is 45 minutes up to 4 hours. So a lot of variability. Half-life is 24 hours, and it's lipophilic, so it will hurt the veins a little bit. Uses seizures. So it's the king of seizures, right? Everybody seizures, run for the Ativan, 2 milligram, and then. But I have a request. If I come to the ED with seizure, right, give me only 2 doses of Ativan, and that's it, intubate me after, right? Because the shit that happens with Ativan and another Ativan, and then 6 hours later another resident comes in, and then the patient seizes again, another Ativan, and then another Ativan. So what's happening is that we kind of underestimate, seizure is not benign, right? Of course, I'm sorry, let's put it this way. Seizure is, for the most part, is benign, but it has a potential serious side effect, right? So yeah, you get away with seizure all the time, but if I aspirate, I'm going after you, because you keep giving me Ativan and you don't want to intubate me in the 21st century and put me on 12 hours of vent and then extubate me again, right? The American, so there is some algorithm out there for seizure, and for the longest time that an algorithm did not even include propofol. Was not identified as an anti-seizure medication, which is probably the best anti-seizure medication. Will give you isoelectric activity. So it wasn't even identified. And then just 2 years ago, I think 2017, they just put propofol all the way down to the end. Still too much. Ativan, phenytoin, phenobarb, Keppra. All of this, like half hour or not even more than an hour. I probably bit my tongue. I vomited and aspirated, jumped off the bed, and even forgot about this lecture because of the supply demand. You can actually infarct areas of your brain that are at risk. So 2 times is fine. It can be used for DTs, and we know we can use it for C1. Also, we know we can use it also for drips. Intubated patients. We stopped using it for intubated patients about a year ago or so, but it can be used for intubated patient. It's 0 to what, Professor? No, 10. Trick question. Huh? Why 10? This used to be a board question. I don't know if it's still a board question. but because of the propylene glycol. So there is a limitation of how much ativan you can give because it has propylene glycol, which is similar to ethylene glycol. It will give you high anion gap, high osmolar gap, metabolic acidosis. So that's why I have to measure the gas and serum osmolarity every 3 days. Number 4, and by the way, this is actually, when you do 10 milligram an hour, at the end of the day, you actually passed the WHO published toxic dose of propylene glycol already. Number 4, we can use it for procedural sedation, but who wants to give that anymore? You know, so falling out of favor. Valium, 10 to 15 minute half-life, and about 4 to 8 hours. Onset of action, half-life, the duration of action, half-life is 16 hours, and it's very lipophilic. So it will injure the vein. Very high incidence of having phlebitis from Valium, especially with the high doses that we give. Really, very, very high incidence. Uses. So there are things that we can do, by the way, to decrease this injury. Rotate the veins. Obviously, central line is better, right? But rotate the veins. Aspirate blood into the syringe before injecting it back again, the Valium. And obviously make sure that the veins are patent and stuff like that. So it can be used for seizure. You have to use like a 10 milligram IV or something, and that will give you, but it'll take time. But the times I use it for seizure, and I love it, are the times where we have those congenital syndromes that seize all the time, all their lives are seizing, and they have like 5 anti-seizure medications. And then they're coming in and I want to send them home or to the floor with something extra, additional, because they're still seizing. So I give them Valium, IV or PO. I know that this is not going to put them to apnea. You know, it's safer than the other ones. And then of course DTs. So it is a medication that has been made a comeback in DTs. It made a comeback in DTs and based on 2 studies. And we'll talk about that in details when we talk about the DTs protocol. And that is it.